Hey everyone, welcome to another video by Books, Medicine and Scrubs. In this video, we're going to talk about various disorders and pathologies of the stomach. The first topic we're going to cover in this chapter is the management of epigastric pain. The epigastric region is the part of your abdomen just below the sternum. If a patient comes to you with pain in this region, you have to first see whether certain alarm symptoms are present. What are these alarm symptoms? Pain in a person who's older than 50 years old, epigastric pain in an anemic person is complaining of dysphagia, person has complaints of weight loss, and any kind of bleeding sign like heme-positive stools or hematemesis. If these signs are present, you do endoscopy. If they're absent, you check for H pylori. If the person is positive for H pylori, you treat the bacteria. If it's negative, then you treat with proton pump inhibitor. If there is still refractory pain after treatment with proton pump inhibitors, then you have to do an endoscopy. This is a table talking about all the alarm signs that we just discussed. So let's start with various pathologies of the stomach. The first one is gastroesophageal reflux disease or GERD. What are the symptoms of GERD? The symptoms are heartburn, also known as spirosis, difficulty swallowing and a metallic taste in the mouth, water brash or hypersalivation, chronic cough, hoarseness or wheezing, regurgitation of food, chest pain, and globus sensation, which is defined as the sensation of something being stuck in the throat. Now, since this condition has chest pain as a symptom, the first thing to do is an ECG. In any chest pain patient, you always have to rule out a cardiac cause of pain. So, gastroesophageal reflux disease is defined as a pathology caused by the abnormal flow of acid gastric contents backwards from the stomach up into the esophagus. The lower esophageal sphincter is not a true anatomic sphincter, and it's created by the different response of the smooth muscle cells in the distal esophagus. And when the tone of the sphincter decreases, acid tends to reflux backwards into the esophagus. Hence, it's even worse when the person is lying down on his back, and so many patients who have GERD will have more reflux when at night when they're sleeping. So what are the factors that cause this decrease in tone of the lower esophageal sphincter? They are nicotine, alcohol, coffee, too much coffee like medical students drink. That's why it's such a frequent problem. Chocolate, anticholinergic drugs, calcium channel blockers, nitrates, all of these can reduce the tone of the lower esophageal sphincter and cause acid reflux. So, when it's a very mild case, it can be easily managed by lifestyle changes. Pregnancy and obesity increase the occurrence of GERD, hence exercising definitely helps in managing this. Other than that, you have to avoid foods that tend to increase gastric acid reflux. So avoid heartburn triggers. You have to chew food well, eat smaller meals, don't wear very tight clothing, quit smoking, sleep with your pillow elevated. It really works. And minimize the coffee and alcohol consumption. And you have to go to bed on time, like after 3 hours of the last meal. So how do you diagnose GERD? The most accurate test for GERD is a 24-hour pH monitoring However, it's not usually done because, as you can see from the picture, it's a very complicated test. You have an ambulatory device called a monitoring device, which is attached to the patient's belt in the picture, and then there is a catheter attached to it, which passes through your nose and the nasopharynx and through the esophagus and reaches the lower esophageal sphincter and monitors the pH in that area. It doesn't go all the way down to the LES, and it stays a few centimeters above the gastroesophageal junction so that it can see whether acid is getting refluxed upwards. So a determination is made by what the average pH in that area is. Normal endoscopy cannot help to exclude reflux disease, but you do endoscopy even in a patient with GERD and alarm symptoms. However, you tend to keep this test as a last resort because we initiate proton pump inhibitors usually right away. It's the it's the starting first line therapy without doing any investigation. Because when it's a clear case of epigastric pain under the sternum associated with respiratory complaints, a bad taste, and cough and hoarseness, you just give PPIs. If PPIs don't work, you increase the proton pump inhibitor dose to twice daily for 4 to 8 weeks and make sure the patient is taking them properly. If still there is no improvement, only then do you do endoscopy or esophageal gastroduodenoscopy. If that shows esophagitis, then that confirms GERD, and then 24-hour pH monitoring is not needed. However, if the endoscopy is normal, then you have to do an ambulatory 24-hour pH monitoring while off the proton pump inhibitor. So straight away, PPIs be a common question on the board, so you have to be prepared for them. So here is a table outlining the management of GERD. So you can see the first point is to start proton pump inhibitors. If there is improvement, then this is a diagnostic and therapeutic method. It diagnosed GERD and then it's treating it too, and continue the treatment with the same dose of PPIs and lifestyle modification. If there is no improvement, you increase the dose to twice daily and also ensure that the patient takes the pills at the right time, 30 to 60 minutes before meals. If there is still no improvement, then you do an endoscopy. If the endoscopy or esophageal gastroduodenoscopy is normal, then you do an ambulatory 24-hour pH monitoring. And if results show GERD, then you have to do a surgical procedure called Nissen fundoplication. However, if endoscopy shows esophagitis that confirms GERD, then 24-hour pH monitoring is not needed. Now we come to the next disorder of the stomach and the lower gastroesophageal junction called Barrett's esophagus. Now, Barrett's esophagus is a complication of long-standing GERD. After many years of GERD, like more than 5 years of GERD, the epithelium of the lower esophagus it undergoes a histologic change from a normal stratified squamous epithelium to a columnar epithelium. You can see in this picture how the squamous mucosa looks and how the columnar mucosa looks. So when the squamous is converted to columnar intestinal metaplasia, that's called Barrett's esophagus. So what are the causes of Barrett's esophagus? Long-standing GERD, more than 5 years to develop, Each year, 0.5% of people with Barrett's esophagus progress to esophageal cancer. Hence, it's important to screen patients for Barrett's because they have a high tendency to develop cancer, and that is lethal. So you have to do repeat endoscopy or EGDs in them every 3 to 5 years to see whether esophageal dysplasia. So endoscopy with biopsy is done so that the histology can be seen, and you have to start them on a course of proton pump inhibitors. But remember that PPIs don't prevent progression of Barrett's esophagus to cancer. They just help in preventing esophageal strictures. Because what are the complications of GERD? It leads to esophageal strictures, and that causes dysphagia, and proton pump inhibitors prevent the occurrence of these strictures, because once they occur, the only treatment is dilatation. Other than that, they can cause Barrett's esophagus, so you have to start them on a course of PPIs along with lifestyle modification. So if the person has only Barrett's esophagus alone, metaplasia, then you give proton pump inhibitors and repeat endoscopy every 2 to 3 years with biopsy. Remember the number, 2 to 3 years. If there is low-grade dysplasia, then proton pump inhibitors and repeat endoscopy every 6 to 12 months. If there is high-grade dysplasia, then you have to get rid of that part of the lower esophageal, gastroesophageal junction because it's too risky. You do conduct an endoscopic ablation or a photodynamic therapy, radiofrequency ablation therapy, or endoscopic mucosal resection, and you get rid. Now we come to a very, very important topic, which is actually the heart of stomach disorders, because so many questions are based on it, and it becomes a little tricky. It's a pretty simple topic, but becomes tricky because of the varieties of management algorithms that are there. So peptic ulcer disease covers both gastric and duodenal ulcers. Most common causes are, again, Helicobacter pylori bacteria, NSAID abuse. NSAID abuse causes ulcers which bleed more than the pain. Alcohol and tobacco don't cause gastric ulcers, and they only delay the healing of the ulcers. Less common causes of PUD are burn patients, head injury patients, gastric cancer patients, normally have gastric ulcers, Zollinger Ellison syndrome, and prolonged mechanical ventilation. All of these cause peptic ulcer disease. Diagnosis of peptic ulcer disease. So before we start with that, we just need to know a little basics about peptic ulcers. You have to know that there are 3 hormones which are responsible for the production of gastric acid. These are gastrin, acetylcholine, and histamine. And stimulation of gastric acid release is done by gastrin hormone. And the secretion of gastrin hormone is from the G cells of the stomach, which is stimulated by distension of the stomach. When food gets into the stomach, it distends and releases gastrin, or amino acids, or vagal effect, or increased gastric pH. And histamine is released by enterochromaffin-like cells present in the same glandular elements of the stomach that have the parietal and the chief cells. The chief cells release pepsinogen, which is converted to pepsin by the acidic environment of the gastric lumen and helps in digesting proteins. And histamine directly stimulates the parietal cells to both release acid and potentiate the effects of acetylcholine and gastrin on the parietal cells. That's why H2 blockers like cimetidine, famotidine, and ranitidine inhibit acid release. So, you have to just know that the parietal cells in the stomach are responsible for release of acid and are stimulated by gastrin, acetylcholine, and histamine. So, diagnosis of peptic ulcer disease. Endoscopy is the most accurate test for diagnosis, and it can even help collect a biopsy sample for histological purposes. However, it's a very invasive test. These are pictures of ulcers. You can see a duodenal ulcer and a gastric ulcer. However, it's a very invasive procedure, so we tend to do it only when it's absolutely necessary. Other radiological testing is not very sensitive. And so the diagnosis is usually done clinically when very telltale signs and symptoms are present. We just start with the therapy before we even diagnose an ulcer. It's important to test for Helicobacter pylori. Now this slide talks about endoscope and how endoscopy is done. You can see how in the first image, how the endoscope enters from the mouth and reaches the esophagus and the stomach, and sometimes even the duodenum. So this is upper endoscopy, which is called the esophageal gastroduodenoscopy. The second image, if you go clockwise, talks about how the patient is positioned on his side when endoscopy is done, and the images can be seen on a monitor. The third is a close-up image and a real-life picture of a doctor holding an endoscope. You can see that the tip has a light which helps visualize areas. And the last one is another depiction of a doctor conducting endoscopy. So, you do an endoscopy in case of when there is a doubt about the diagnosis. If it is positive for a bleeding ulcer, then you try to repair that by injecting epinephrine or cautery, and if it is positive for H pylori, you start treatment for. So treatment, most peptic ulcer disease responds to proton pump inhibitors. If it's positive for H pylori, then it needs to be eradicated for sure, because otherwise the ulcer will recur as soon as the proton pump inhibitors are stopped. And we know that long-term proton pump inhibitor use has side effects. What are these side effects? It can lead to osteoporosis. It can lead to antibiotic-related diarrhea, Clostridium difficile infection. It's hard to treat Clostridium difficile when the patient is on proton pump inhibitors. It can lead to aspiration pneumonia. Like aspiration, it happens physiologically all the time, and the acidic content sometimes enter the lung. However, when the acidic content is more alkaline because of proton pump inhibitors, it increases the chances of aspiration pneumonia. Okay. So ulcer evaluation. Now you know that there are two types of ulcers. We have gastric and duodenal ulcers. Duodenal ulcers are 80 to 90% of the times positive for H. pylori and rarely positive for cancer. But gastric ulcers are only positive for H. pylori in 50 to 70% cases, and in 4% cases they are positive for cancer. Hence, endoscopy is more important in cases of refractory pain in gastric ulcers even after treatment, or when alarm signs are present, because the chances of cancer to get cancer. Treatment for H. pylori. There are two protocols followed. The first is triple therapy. The second is quadruple therapy. Quadruple stands for four drugs. Triple therapy is definitely better. And in this, you give proton pump inhibitors like omeprazole, lansoprazole, clarithromycin, and amoxicillin. If the person is allergic to penicillin, you can replace amoxicillin with metronidazole and give it for 14 days, followed by proton pump inhibitors alone for 4 to 6 weeks. If this therapeutic regime fails, then you have to shift to the quadruple therapy. The quadruple therapy has 4 drugs, and the new one that's added is bismuth subsalicylate. Other than that, you have tetracycline, a new kind of antibiotic. The rest, metronidazole and proton pump inhibitors, are the same. Now, once you give a patient therapy with triple or quadruple therapy, you have to check whether the Helicobacter pylori infection has been eradicated or not, because it has a tendency to recur. So for that, these are the tests that are available. You can do a urease breath test, which is non-invasive, or a stool antigen test, which is also non-invasive. But both of these, stool antigen testing will need a stool sample, which is kind of yucky, and urease breath test is also, it has cons too. Biopsy with histology is very invasive, but it's the best test. Rapid urease test, Campylobacter-like organism test, is also invasive. You never do serology in case of checking for eradication of H. pylori, because once the patient is positive, he's always positive. So you can't find out whether the infection has been eradicated or not. Now you have to make sure that your patient is off proton pump inhibitors for 2 weeks and antibiotics for like 4 weeks before you conduct these tests. Otherwise, you'll get a false negative report. Now we come to a new topic, that is gastritis. I'm so excited. I don't know why, but yeah. So gastritis is a condition that does not involve ulcer formation. It's like pre-ulcer stage. There is just inflammation or erosion of the gastric lining, which can be mild, moderate, or severe, and there may be hemorrhage present or absent. Now, gastritis is also of 2 broad types, acute and chronic is further divided into type A and type B. Acute gastritis is caused by H. pylori or other infections, alcohol, NSAIDs, and stress. That's why a lot of students have it. Chronic type A gastritis is called atrophic gastritis, and it's an autoimmune condition, also known as pernicious anemia popularly. In this, there are antibodies against the parietal cells, an intrinsic factor of the stomach. The parietal cells are responsible for acid secretion, so there's atrophy of these cells, and food is not digested properly. And then there is a loss of intrinsic factor called Castle intrinsic factor, which affects the absorption of vitamin B12 and can lead to megaloblastic anemia, ataxia, or peripheral neuropathy, because vitamin B12 deficiency can lead to subacute combined degeneration of the spinal cord. Chronic type B is actually the most common one, and it can be due to alcohol, NSAIDs, Helicobacter pylori, head trauma, burns, mechanical ventilation. It is also associated with an increased gastric acid production. Now, what are the clinical features of gastritis? Some important features are asymptomatic bleeding. Why? Because pain is a late feature of this condition. If there is severe erosive gastritis, then you can have epigastric pain, but usually the person just comes in with bleeding. Blood in the vomit, called coffee ground emesis, blood in the stool, called melena, or nausea and vomiting. And sometimes the pernicious anemia signs may also be there, like megaloblastic anemia, ataxia, or peripheral neuropathy. That's clinically. But the diagnosis otherwise is the same. You have to conduct tests for Helicobacter pylori if you suspect that it's gastritis by H pylori. If you suspect NSAID-induced gastritis, you have to take a detailed drug history. So that's how you diagnose it. If you want to diagnose pernicious anemia, you have to measure methyl malonic acid levels. So when malonic acid levels are raised, it's the most accurate test to confirm diagnosis. Gastric pH is high, intrinsic factor is low. Parietal cell antibody is a very sensitive test because that's what the antibody is formed against. It's an autoimmune condition. Intrinsic factor antibody is the most specific test. Schilling test is obsolete. So just remember that the gastric pH here will be high. Why high? Because acid is not being secreted, so the environment inside the stomach will become more alkaline. The treatment is with parenteral vitamin B12. You have to inject vitamin B12 into the body. You can't just give it orally at this stage. Other than that, you have to give proton pump inhibitors and do stress ulcer prophylaxis. Whenever somebody comes to you with a head injury or with burns or is in prolonged mechanical ventilation, you need to start them on proton pump inhibitors. You can even give them PPIs IV so that they don't develop also gastritis. And now we come to another condition that leads to ulcer formation. That's Zollinger-Ellison syndrome, or ZES. It is hypergastrinemia caused by cancer of the gastrin-producing cells. There is no known cause for gastrinoma. Now, half of these, you can see in this pie chart, 50% are located in the duodenum, 25% are in the pancreas, and a small percentage are due to men or multiple endocrine neoplasia 1 syndrome. It's the 3P condition. Why? Because it has hyperparathyroidism, pancreatic islet cell tumor, most common is gastrinomas, can be insulinomas too, but gastrinomas are more common. And pituitary adenomas. Remember that pheochromocytomas happen in men too and not in this condition. The patient will complain of diarrhea because acid inactivates the pancreatic lipase. There may be abdominal pain due to the ulcer, anemia due to bleeding ulcer, heme-positive stools may be present with occult blood. So now this is a very cute diagram explaining how Zollinger-Ellison syndrome works. There's a triad of ZES, which I've taken from Creative Med Doses. So first, there is a pancreatic or duodenal tumor that releases gastrin, and this gastrin causes gastric hypersecretion. Gastrin has stimulatory effects on parietal cells and enterochromaffin cells. Parietal cells secrete acid, and enterochromaffin cells release what? They release histamine, and that causes multiple peptic ulcers refractory to medical treatment. Ulcers are at unusual places, so normally you find ulcers in the stomach and the duodenum, but when they are even found in the jejunal ulcers always point towards a gastrinoma. They just don't happen on their own through bacteria or diet. Now, how do you diagnose ZES and how do you manage it? You perform an endoscopy first, and if that endoscopy detects, let's say, a jejunal ulcer, then you have to first check gastrin levels after proton pump inhibitors and H2 blockers have been weaned off for several days. Otherwise, they will cause false negatives. They will cause false positives, sorry, because then they will make it look like the gastrin levels are high because they obviously inhibit the acid and then gastrin will increase as a result. High gastrin level despite a high gastric acid output, because the gastrinomas don't respond to feedback inhibition. Most accurate test is persistently high gastrin even after injecting secretin, because secretin is supposed to inhibit gastrin secretion. So after diagnosis is confirmed, you exclude metastatic disease. How do you do that? First is somatostatin receptor scintigraphy for metastasis. That's gold standard, along with simultaneous endoscopic ultrasonography for primary tumor, which is present, which may be in the pancreas or duodenum, that can be detected through endoscopic ultrasonography. Gastronoma is associated with a massive increase in somatostatin receptors in the abdomen, and they can be detected by somatostatin receptor scintigraphy. And the endoscopic ultrasound detects lesions in the pancreas, the primary tumor. Other modalities like normal USG, CT scan, MRI, they have poor sensitivity, only 60 to 80. Now, this is a very high yield table about Zollinger Ellison syndrome. You have to classify it on the basis of serum gastrin level. When it's less than 110, you know it's not ZES, because gastrinoma, come on, has to secrete gastrin. If it's between 110 to 1000, you have to measure the gastric pH. If the pH is low, then you know that acid is high and you have to do a secretin stimulation test. If it's positive, then it's Zollinger-Ellison syndrome. If it's negative, then it's something else and not ZES. But if the pH is high, if it's an alkaline environment, you have to know it's pernicious anemia. Gastrin is high because the feedback inhibition from the acid secreted by parietal cells is absent, because in pernicious anemia, the parietal cells have been destroyed by autoantibodies. And when the gastrin levels are really high, more than 1000, as you can see in the last part of this flowchart, then again you measure pH. If pH is low, then it's Zollinger-Ellison syndrome, because such a high level of gastrin cannot happen without a gastrinoma. And if the pH is high, then it's pernicious anemia. So now we're done with all the conditions that deal with gastric ulcer, and we come to a very different condition called gastroparesis. Now, gastroparesis is called delayed gastric emptying. It results in delayed movement of food from the stomach to the small intestine. The most common cause is diabetes. Other causes are electrolyte problems with potassium, magnesium, and calcium. So, the most common cause for this condition is diabetes. It can damage the vagus nerve and the special cells in the walls of the stomach. So, the sphincters and there is neuropathy in the stomach, and the stomach cannot sense that it's becoming distended, and the sphincters don't open, the sphincters are closed. So loss of muscles to move food through the digestive tract, damaged vagus nerve, food stays in the stomach too long. So what are the symptoms in the patient? The patient presents with early satiety, because the stomach has food in it already. There is postprandial nausea and a generalized sense of increased abdominal fullness due to decreased motility of the stomach and the accumulation of food there. There's bloating and abdominal pain, especially in someone with a long-standing history of diabetes. and poor glycemic control. They will have other associated diabetic symptoms too, like retinopathy, neuropathy, nephropathy, might have a diabetic foot ulcer. So you have to check for all the. So here you can see another picture. You can see how normal gastric emptying takes place. There are peristaltic contractions all over the stomach which push the food. There is the lower esophageal sphincter closes, and then the strong peristaltic contractions push the food through the pyloric sphincter. In gastroparesis, the pyloric sphincter is closed, the movement is really slow, and food is stopped within the stomach. So, how do you diagnose gastroparesis? You do a gastric emptying study. It's really interesting and really high tech. In this, a radionucleotide labeled food particle is given to the patient, and then it's measured. The radioactive particles emit a certain fluorescent light, and that's measured uh, at an interval of a few hours to see how much food has emptied the stomach. I have an image of this in the next slide. And it's a really good test, but it's the most accurate test, but it's a really complicated, expensive, and kind of invasive. You're exposing the person to a radionucleic substance. So we try to avoid this and try to diagnose it through clinical practice only. Also, there is when food gets collected in the stomach, so when you're palpating it, sometimes you hear a splash called the succussion splash. You have to look out for it. So the most normally if a person has long-standing diabetes and then they have these symptoms, okay, and when you do an endoscopy, you will see that there's food in the stomach, then you assume that it's diabetic gastroparesis. It's only when there are cases where there is a doubt, then you have to measure the transit time through the stomach of a radioisotope. You have to make sure that blood glucose is below 275 milligrams per deciliter because severe hyperglycemia can impair gastric emptying. Now, you have to avoid eating too much food in one go for smaller meals. These are all lifestyle changes. Eat food low in fat and fiber, eat slowly, do yoga, and take medicines to boost digestion and motility, like erythromycin, a macrolide. It's used as a pro-motility agent. However, it has side effects because it affects the heart, can increase QT prolongation, and increase the risk for torsades de pointes, and this is a general side effect with all macrolides. And metoclopramide can also cause tardive dyskinesia, and it's also a pro-motility agent. Now this is an image of gastric emptying study, and you can see how in accelerated gastric emptying, how the stomach is 100% empty by 4 hours. Whereas in delayed gastric emptying, as is seen in gastroparesis, the stomach is only 30% empty at the end of 4 hours, and just 8% empty at the end of 2 hours, whereas an accelerated gastric emptying or normal is about 90 to 97% empty. So this is such a beautiful depiction of gastroparesis. So gastroparesis has been like summarized into these signs. You have upper signs, nausea and vomiting, lower signs, bloating and constipation, neurologic symptoms, anorexia and early satiety, and endoscopic symptoms, large amounts of retained food, and succussion splash. Now, as we reach the end of this video, we're doing the last topic of this video, that is dumping syndrome. Now, dumping syndrome is a very interesting syndrome, and it's really rare now and was more common in the past, where vagotomy and gastric resection were performed to treat severe ulcer disease. It's a very rare disorder in which two phenomena occur. The first one is early dumping syndrome, the second one is late dumping syndrome. So this is a person who has eaten something, like let's say is eating bread, and in 50 to 30 minutes after eating there is epigastric fullness, and you can see a small dumping vehicle is dumping all the high carb, high fluids into the duodenum. The person starts feeling weak, dizzy, vertigo, and starts sweating, tachycardia, abdominal cramping, self-limiting. And what the treatment here is: no liquid with meals, no high carbs, no bread, no potatoes. So what this person is suffering from is a dumping syndrome. And this is a flowchart of how dumping syndrome happens. When there is emptying of hyperosmolar carbohydrate containing chyme into the small bowel very rapidly, then it acts as an osmotic draw and causes intravascular volume depletion. Okay, and that leads to a sudden peak in glucose levels in the blood because of the rapid release of food into the small intestine, causing hyperglycemia. So in early dumping, two things take place. It happens in less than 60 minutes. Increased intraluminal sequestration, hypovolemia, because the osmotic gradient, the high glucose chyme, it acts as a increases the osmolality of the intestine, and it draws all the water, so the person has hypovolemia. There is vasomotor response, tachycardia, sweating, abdominal distension, and there's hyperglycemia because increased movement of food into small intestine. However, in 1 to 4 hours there's late dumping because the excess glucose causes excess insulin release, and that suddenly causes the glucose levels to fall, leading to hypoglycemia. So that's what happens in late dumping. Why the kind of symptoms that you'll see in early and late dumping syndrome will be different. Early dumping syndrome will have symptoms of hyperglycemia and volume depletion, sweating, blush, tachycardia, abdominal pain, diarrhea because of all the fluid that's entering into the intestine along the osmotic gradient, and nausea. Late dumping syndrome will have signs like hypoglycemia that can happen in a diabetic patient after taking insulin, sweating, tachycardia, hunger, unconsciousness, somnolence, tremor, irritability. So before I end this video, how will you treat dumping syndrome? The patient comes to you with sweating, palpitations, and lightheadedness after a meal. You'll tell him that there's no treatment as such. It's usually supportive, and you have to eat multiple meals. You can give the patient octreotide, which is a somatostatin analog, and that decreases gastric secretion and gastric motility, and it might help the patient. So that's all about stomach disorders. This was a really long topic, and so I hope you understood it better.